Good morning and welcome to today's SIM Forum. Thank you all for joining us. My name is Sarah Durr and I am the Med Management Lead here at the Iowa Healthcare Collaborative. We're really excited to have this amazing panel with us today to discuss such an important topic, which is around opioids and diabetes management. And today we will start out with reading the case scenario. I will then introduce each of our panelists. Actually, I'm going to do introductions and then we'll do the case scenario. And then each of the panelists will have about 5 to 7 minutes to discuss kind of how they would handle this patient, questions they would ask, and any other things that they would like to share with us. We will then allow them some time to be interactive and discuss amongst each other, do some care coordination piece, and we'll finish off with questions and answers. A couple of housekeeping things. All of your lines are currently muted. As time allows, there will be time for question and answer after the panel discussion. You can use your Zoom chat function to send questions directly into everyone or to our administrator. And for your information, today's session is being recorded and will be available on the IHC YouTube channel in the next couple of days. So with that, I will start out with just a quick introduction of all of our panel members. Immediately to my left here is Lee Kral. She is a pharmacist who has her PharmD from the University of Iowa. She currently is a clinical pharmacy specialist in pain management at the University of Iowa Clinics. Next, we have Joan Kitten, who is a nurse practitioner at UnityPoint Primary Health Care, and she is certified in both family practice and psychiatry. Jennifer Wuebker is next, and she is a care coordination at Webster County Health Department. Next, I have Dr. Nicole Gastala, MD. She graduated from the University of Iowa and is at the Primary Health Care. Next is Andrea Storjohann. She's a registered nurse and TCADC at Primary Health Care. And then I have Jackie Pippin, who is our Quality Improvement Advisor at the Iowa Healthcare Collaborative, and she was previously at Primary Health Care. Our case today, we have a 68-year-old female who has moved from Decorah, Iowa, and is establishing care with a primary care provider. She was diagnosed with diabetes 15 years ago and recently has been poorly controlled with an A1C of 9%. 4 years ago, she was diagnosed with chronic back pain and began taking Oxycontin 10 milligrams twice daily and hydrocodone acetaminophen 500 milligrams every 4 hours as needed. This is her first visit with her new primary care provider. Her primary concern today is that her pain has been worse in the last couple of months and she thinks she may need to increase her pain medication. She states that her pain has been so severe that she has been in the emergency department on a weekly basis to get additional medication for her pain. Relevant social history is that her husband passed away about 6 months ago, and she is moving to be closer with her 2 daughters so that she actually can have a little bit better care from them. Family history: her father died at 58 years of age from liver failure due to alcoholism. Her mother had diabetes and died of cardiac complications at the age of 72, and her brother and sister both have diabetes and have struggled with depression over the last decade. So with that, I'm going to open it up to our panel, and let's actually start with Dr. Gastala.
So the very first time that I see a new patient, the most important thing to do is get a full history, review the records if you can beforehand. And just because they are establishing care does not mean that I prescribe narcotics the first time that I see them. It's really important to kind of get that full view, make sure that you properly diagnose, just because you don't know if what the diagnosis was previously. So the first thing I would do would be get a thorough history on her back pain, as well as her diabetes and any other health problems that she has. Look through the records, and what's important in terms of back pain based off of this new CDC guidelines is you want to see what else they have tried. What med trials, what non-opioids did she try first? Did she try physical therapy? What is her weight? Does she participate in any exercise? What imaging has she had done? What exactly is her diagnosis? I know it says chronic back pain, but what specifically about that? And then do a pretty thorough exam. Also assess if there's been any injury or trauma, and then discuss with the patient why it has been worse recently, I think is also really important, and to dig around with that. Also, any patient who's on a controlled substance that I see, I always pull a PMP. And then if I am considering prescribing narcotics, I do urine drug screen as well. Another important aspect for this patient is to discuss her diabetes. What medication is she on? How she's taking the medications, how she feels it's working for her. Her A1C is 9, which is, not great, but not the worst, I've ever seen either. So I would discuss with her about what medications and how her compliance has been, any barriers she's faced, maybe from transferring care. She hasn't been able to pick up her medications. So that's really important. And then I would talk to her a little bit about the social factors that have been going on. I think it's really important at this time to do a depression screen because of her husband's passing about 6 months ago. And then kind of open up the forum to discuss with her. Does she feel that her pain has been worse since her husband has passed away, and try to dig deeper into that to see if that could be contributing, because so many times emotional pain can present as physical pain. So it's really important to assess and treat depression as well. And then figure out what her support system is, I think is also really important. And so obviously this all takes a little bit of time, but if you really want to do right by the patient, it's really important to gather all of this information. So that's kind of how I would go about it first. I wouldn't necessarily prescribe opioids that day, because you do have to screen for opioid use disorder, because there are some warning signs that I see just based off the history, and may perhaps find more in talking with the patient. So I would probably see them back rather soon, within the next couple of days or the following week after I've had time to review everything. So that's kind of how I would go about with that patient. So
wonderful. Joan, let's pass it off to you next.
I agree wholeheartedly with Dr. Gastala as far as checking the PNP and screening for other opioid use disorders, and also depression, of course. We use a PHQ-9 because it's part of our electronic health record, but there's lots of other measurement tools that you can use, like the HAM-D, the VAX, MADRS scores, etc. So, one of the first things that I thought of when I looked at this scenario was really in the title, opioid use in uncontrolled diabetes. When I look at that, it automatically forces me to almost blame the person, to the lady that's presenting to me that she's using opioids. Well, actually, it was her prescriber that gave her the opioids in the first place. And so I think that you're exactly right, backing up and looking at how those prescriptions were given to her, what else she's tried. Obviously, that's what you have to do. The other thing, so when I look at that, I think to myself, well, the thing that she actually has more control of perhaps is her diabetes, not so much her opioid use. So it maybe would be something more like undermanaged back pain in a client with undermanaged diabetes, if you want to think about it that way. I think one of the things when I used to do much more in primary care, and now I see a lot of folks with primary mental health concerns. I remember having the nurse room my patient, and their chief complaint or reason for visit would be, and that might be in this case, reason for visit, pain medicine not working, needs more, right? So then that sets us up as prescribers to look at the fact that she is potentially drug seeking instead of looking at the client first. And so I think that really screening her, as Dr. Gastala was saying, and also really looking at the depression and the things, the husband passing away. The other red flag in the scenario for me, of course, as a behavioral health person, is her father's death due to alcoholism. We see a large proportion of clients in our mental health practice that have co-occurring depression, back pain, and substance use, or perhaps opioid use, and you really have to ferret that out and almost go back to whether this lady's 68 or whether she was 8, how her childhood has affected her now, and also the recent death of her husband. So really looking at that is important. I, of course, have lots more questions as to how else she's managed, like you were saying, how else she's managed her back pain, but also her diabetes. What else has she done besides utilize opioids? And is she been treated for depression? When I see a client and they have a medication list that's 10 meds long and a diagnosis list that might be, 20 different concerns, it automatically, and I'm not saying that's where this lady is, but it's flagged to me that we really need to look at the behavioral health end of things. And also before I quit, I think the other piece of it is how I started the conversation, in that how we as prescribers or providers walk into a case scenario with that patient in any given situation. It's important. I think it was Hippocrates that says first do no harm, right? So sometimes I don't like the fact that as a nurse practitioner, I'm labeled as a prescriber. That's somewhat my value in the health system. I get paid a whole lot more to be able to prescribe, but really what my job is to listen to the patient, find the best scenario for them and the best treatment for them. And lots of times that doesn't involve opioid use. The other thing that I think that's really awesome as time goes on is the integrated care that we have now. 15 years ago, when I saw a client like this and she presented to me with depression, I would have not had any idea, or there wasn't a PMP, there wasn't an electronic health record. She would come into the office and say, I'm here because somebody told me to come and they think I'm depressed, and it would take me quite a bit of time to get to the meat of the back pain. And now and I appreciate being here to be able to talk about the whole client and the integration of physical and mental health.
Thank you both. I think you hit on some really key points around the prescription monitoring program, looking at depression, that piece around addiction as a potential, kind of having that behavioral health side of things as well. So I really appreciate you sharing that.
I think it's also important as well to set the tone with the patient the first time you meet them, say that we're really here to get to know you, your whole history. It's not just to give you a prescription, just like you said. Right. And it's so important to, just because they've been given narcotics doesn't mean that's in their best interest. And it may not be necessarily the next best step for them. So having that honest conversation as well, saying we're going to look at your whole history to, make sure that you've tried all these other modalities that have better evidence behind them, and we need to have that as part of the discussion with the patient. So I think that's also really important.
Well, Lee, I know you've had some very unique experience as a pharmacist in the clinic setting. Do you want to share your thoughts on the case?
I have, and I can. Not only from doing pain management for the last 16 years, but prior to that, I was in primary care in a VA hospital. And I worked a lot with more elderly patients, and particularly around this time of year, or when a spouse dies or a friend dies, and as they get a little bit older, thinking about their own mortality, we start to get more stress, more depression, as you have seen. The first thing that I thought when I looked at this was, this poor lady, she is obviously suffering. And the first thing, in my scenario, it would be the two daughters that had brought her into our pain clinic and said, you got to fix her, she's addicted. That's typically what we get, as a family member steps in and says, you got to fix my mom and she's an addict and we don't want that. And it's like, calm down. This is not necessarily an addiction issue going on, but maybe rather, again, getting down to the meat of it, what's really going on with her. She's had a lot of turmoil and turnover and strife and grief in her life. And what we see, again, at this time of the year is that emotional stress, and again, her physically moving to a new town, a new community, leaving friends behind, a local, caring community behind, is very stressful for patients, and pain naturally increases. When our neurotransmitters aren't balanced, we have more pain. And so there's not only a psychological component to that, but a biological component to that. So for me, in addition to all the things that Dr. Gastala and Joan have said, is that checking, getting all the data, checking the prescription monitoring program, looking at the records from the previous, primary care provider, and then addressing her back pain. What we see a lot, and I have the very great honor of working at the university where we have a lot of resources. That being said, a lot of the folks who come to us or come to a big health center in Des Moines is that they come from rural Iowa, and a lot of Iowa is rural. And I come from around the Decorah area. They're lovely towns, but they don't have a lot of resources. They may not have a physical therapist, Decorah does, but they may not have a physical therapist. They may not have a pain clinic that is readily accessible. So coming from a pain clinic standpoint, this is somebody where if I had imaging and I had more diagnostic data, she could be referred to a specialist to take a look at and say, hey, what would you all recommend? Do you feel like an opioid medication would be appropriate for her? Do you think there's some intervention that we could do for her? Do they have a psychologist on staff, or is there somebody locally that we could use within our own practice, that type of thing? But really pooling all those different disciplines in to get after the whole patient. And yes, we don't know what else the local provider had tried, prior to starting an opioid medication. They may have tried many different things, and this is what it ended up being. She may have horrific scoliosis and her spine looks like a roller coaster, and that's why she has back pain. But we need that additional information. And that's kind of how I would go about it too. And you're right, the family history and the social history is really important, because not only do we see a genetic link with depression, but also the alcoholism and substance use disorders. There's a genetic association there. So, this may be transferred down. And, at 68, if they haven't seen other signs of substance use disorder, I suspect it's not going to be a big issue, but it's something that we as providers have to keep in the back of our mind.
Thank you, Lee. Andrea, I'd like to hear your perspective as a nurse in the clinic and kind of how you would go about not only working with the patient right away, but how you would relay some of that information to any of these people that you're working with.
I think my role in the clinic where I work is as the pain management nurse, as well as a TCADC, so I work in a substance abuse treatment center as well. But so my role once the patient is referred to me is to gather information for the provider. So generally speaking, they're either initially coming into the clinic as a new patient because we've got a lot of records and I've been able to sift through them and see maybe they've been prescribed narcotics for a long period of time, or they've been on a narcotic for greater than 3 months. So the provider has said, okay, we want to send them to you. So my role is generally to do an investigation into the past history. Do they have a family history of substance abuse? Do they have a personal history of substance abuse? We do a PHQ-9, we do an SBIRT, we do a cage screen. We do specific pain, location, history of pain. We want to look at previous treatments, previous medications that have been tried and failed. I do a thorough history and type that all up so the provider kind of has access to that more easily. I want to ask, when is your pain worse? When is it better? What are you doing when it's better? What are you doing when your pain is worse? I want to make sure that you're taking your medication like you're supposed to be taking it. Are you taking it in the morning? Are you taking it at night? Are you overtaking your medication? Are you taking it at the beginning of the month so that at the end of the month you're having to go through withdrawal? In this specific case, maybe we would want to find out, is she taking all of OxyContin at the beginning of the month? And maybe that controls her pain. And then at the end of the month, maybe she's having to resort to the hydrocodone, and that's not controlling her pain, resulting in the emergency room visits. We would, of course, check the PMP. We want to get the emergency room records, verify what she's been receiving. I would want to try to gather all of that information for the provider to let the provider know up front, hey, this is what she's telling me. She's telling me this is when she's taking the medication. This is how often she's taking the medication. When she takes it like this and at this dose, it seems to be effective for her. Does this seem to be appropriate to you? We would do a drug screen. A lot of times we want to make sure before we continue to prescribe a medication that drug screen comes back consistent, meaning negative for any controlled substances, because we want to make sure that there's nothing, increasing pain or making them more high risk to continue a narcotic. We want to also make sure that you know, there wasn't any huge injury. We want to get to the source of what this chronic back pain really is. And like everybody else said, you know, obviously she's had some trauma with her husband passing away, and she's got a family history of depression. She's got a family history of substance abuse. I want to find out, you know, is there a dependence going on? We also, you know, we're blessed to have a Suboxone program, so I have some insight into that. So we have just multiple resources. And so my role is to gather all of that information, kind of paint a nice picture, provide it to the provider, and then assist them in making sure that that gets followed and that plan of care gets followed from month to month to month.
Wonderful, thank you. So Jennifer, I know you just heard a whole lot of pieces going on. From your perspective, how would you kind of harness all of this? What else would you look at? What questions would you want to ask?
Okay. As I'm looking at this scenario, I'm just trying to think of where I would probably kind of enter into this scenario. And I could really see me being tied in maybe through the emergency department piece. I sit on basically a weekly meeting, and we talk about high utilizers in the emergency department. We look at frequent hospitalizations, readmissions. The nice thing about this meeting is that we really get the key players to the table. We get to, you know, if it's our FQHC, me at Public Health, and as Home Health, the other home health agency locally, really a medical director, social workers. It's this team that really gets together, and we really try to get down in the nitty-gritty of why all these situations are going on with this patient. And everybody's really touched on a lot of the things that I would say. I know this lady's definitely going through a lot of trauma, even with essentially losing everything that she's probably ever truly known. You know, you lose your home, most likely she's probably had to sell her house, leave everything behind that she had. And I can definitely see why she's doing a lot of these things. So the nice key for me would to take this probably from the emergency department meeting as a referral into my agency. And usually what we do is we would want to do a home visit. So we would want to figure out, you know, how is this patient living? We love to focus on social determinants. Does she have, are these daughters really engaged? Or, you know, there's so many sad situations. Are they taking her medications? Are they really worried about, are they financially taking advantage of her? Those are things that have been eye-opening in my role that I would never believe people would do something like that. So the drug screens could tell us a picture, you know, paint us a picture around some of that. But, you know, once again, is she having falls at home? Does she have the proper equipment? Is her bathroom not on the main level? I mean, there's so many things that could be happening in the home. Does she have the meds that are being prescribed to her? Does she, I mean, you know, there's so many medications that maybe even you guys as primary care don't necessarily know about that we find in the home. So I love making those home visits because you can really see that home environment could be completely different than what's going on in the clinic. If there's a bunch of animals, I mean, there's just so many environmental factors there as well. The other way I see myself as a care coordinator, maybe getting this referral would probably be through either a mental health provider or through a primary care provider. So the nice thing in our areas, we have that really integrated network, I guess, around focusing on mental health, primary care, and us at Public Health. My key piece to this would probably do my best to get them into home health care. We could provide more education in the home around the diabetes. We could form this team, maybe get them plugged into either palliative care or a pain center. And as we're transitioning, hopefully, of whatever the regimen's going to be around the opioids, we could follow up at home and say, this is the way, this is how they're doing it at home. This is really what's going on, and then just work together, care plan, continue with our plan of care through home health, and follow across the continuum and continue to meet and feedback and that kind of thing. That's essentially where I see my role being in this scenario.
You definitely hit on a lot of key pieces in the home that may not be seen in primary care, may not be seen by the specialist or even in the emergency department. So,
right. Thanks.
And I know, Jackie, you've had quite a bit of experience with diabetes and how you want to manage those pieces. What would be your perspective on this patient, and how would you communicate that with your team?
Well, typically, in my role at primary health, Dr. Gastala would see the patient first, Andrea would see the patient first, and then I'd probably be the last person to see this particular patient. In the beginning, if it all happened in one day, I probably would not go in very deep into things, but just really establishing rapport. We were a patient-centered medical home, and I would really try to determine where that person's at, maybe where they've been, and where they'd like to go. So I would use a readiness scale for change and see if there's any goals from what they talk to the provider and Andrea about, see where they want to go, and then use motivational interviewing techniques in order to assess where they are and what they really want to start. What can they start? It depends on finances, their family situation, who's involved, who isn't. Just getting to know the person, really assessing the grief. You know, do they need to go? We had a hospice organization in town that had a wonderful grief support group that met. So maybe connecting that person to that, because the grief can enhance all of these other things. So just really looking at those pieces and seeing then where the patient's at for diabetes. Is it opioids? Is it the pain that we need to control first, or the diabetes? Where they are, because each person is going to be different. So once we get to that education piece, I have a lot of educational materials that I would go over. It doesn't matter how long someone's been a diabetic. There's new information out there, and we don't know how they were taught. So we don't know what those missing pieces are until we can actually get in there and talk to them. So I have some really good resources that I would use for that. Even just meal planning and sharing resources, but I would ask permission because they may not be ready for that yet. So what are they ready for? Maybe they want to get more active. How can we do that step by step? Some people don't know how to set goals. So just kind of teaching them how to set a goal, you know, really assessing where they're at and where they want to go with that. So for some things, it may be a lack of finances now because her husband has passed away. So maybe taking the flyers, the circular ads, and working through. I have a worksheet on, you know, how to build a meal from the flyers that's healthy, that goes along with however much money they have. So I would assess all those social determinants of health. Is there food insecurity? Does she have trouble with transportation? Does she need more insurance? You know, there's a lot of empty questions that we don't know by the scenario, but just kind of picking through all of those pieces so that we see the big picture. Because oftentimes I had the luxury of a little bit more time and could get down to the root of those and then loop back to Dr. Gastala or the other providers so that they could see that big picture. If they needed food pantry, you know, we could get that referral for them. Any of those type of things could just happen through our office. And we were fortunate in the FQHC that we had resources built in. We have a behavioral health specialist on staff, so we could do a warm handoff for the depression areas. And then just tapping them in, I would probably help get them into home care or whatever other resources they would need in the community for that. So it just really depends on what the person needs, where they're at, but really being very cognizant of where that person wants to go. And they may not know at the time, and just finding out what motivates them and allow them to dream a little bit as to where they'd like to go and what they would like their life to be like. So.
Very good. I appreciate the kind of patient activation and self-motivation, talk about motivational interviewing skills. I'm going to open it up for you all to kind of talk amongst yourselves and share your thoughts. But I think my first question that I really had in mind is how do you start that conversation with this patient, whether it's starting from the diabetes standpoint or opioids, how do you start that conversation so that they have a safe space to share with you what they need to so you can make the correct diagnosis or decisions?
And I think that's really actually important, is probably the most important part of this, is initially setting the tone. So I always, introduce myself, shake their hand, and, ask them, tell me a little bit about yourself. Tell me a little bit about your history. And so kind of leaving that as an open-ended question so that they can kind of fill in, because they'll naturally tell you a lot of the information that you need without actually having to specifically ask some of those questions. Eventually, you may have to get more narrow in terms of what medications they've tried and things like that. But I think that says, I personally want to get to know you, and not just you as a diabetic or you as a pain patient, but you as a whole person, because I am not going to, in my experience, I haven't been able to get someone to care about their diabetes if I'm not treating their mental health, substance use, or pain. Right? It's the last on third, and maybe the first on my list because it's going to affect their morbidity and mortality the most, but it's probably going to be one of the lesser items on their list because everything else is so much affecting their life. So I think it's really important to kind of set that tone initially, and just to make them feel like, start that relationship, that they're worthwhile, they're worth my time, they're worth having that active discussion, and that we care about them as a whole person and not just, their diagnosis. So I feel like that always helps set the tone. And then if I don't prescribe opioids that day, because that's where the challenge comes in sometimes, because I then you have to have that discussion, say that first, do no harm. I don't know if this is the most appropriate medication for you. We really have to work on finding the best solution, to help you reach your goals, and to have that pain management. But opioids may not be the best for you. And so if you have that at the beginning, it makes that conversation later much easier. Mm-hmm. So
times have changed with regard to that. As far as in the past, people would come in and say, oh yes, and by the way, I need a refill on my hydrocodone. Now I have clients that come into my office in tears saying, I can't get my medicine from anybody. Can you help me? And so I think that we have set them up to have a preconceived, they're upset and they're hoping to get that from us, instead of backing up and doing exactly what you're saying, sitting down and welcoming them and talking with them about where they've been and what their hopes are for feeling better. And a lot of that, what I do in my practice now, I'm obviously an older provider, and with the electronic health record, there's not as much paperwork, right? But one of the things that I ask my clients to do in the waiting room before they visit with me is write down some of the things that they want to talk with me about. Particularly in mental health, they tend to forget or get anxious, or we're in a hurry and we get past that. So if they can write down what their concerns are, and I can look at that and see where they're coming from, then that also gives me a little bit of a head start as to where to go with our interventions.
I mean, it is scary. I know as a provider, it is having that patient, and I still get some anxiety or feeling whenever I see a new pain patient on my, on my schedule for the day. Cause it's like, oh, how is this encounter going to go? Exactly. And so maybe I think it's so important to step back and look at them as a whole person. And then of course we'll get to the pain management aspect of it, but, just because they've been on it doesn't mean that we continue it, right? But that doesn't necessarily mean that we have to have that discussion today. So we have to gather all that information too. So, but it is hard as a provider, especially with everything going on and all the new evidence that we have. So,
like you were talking about mindfulness, I have to practice mindfulness with myself because we're busy. We have to see. We're seeing a lot of people in the office, and each one of those folks comes in with a different concern and a different look. And so if we can practice mindfulness to try to treat, make good decisions and treat every client, because, in this scenario, someone gave her initially Oxy. So how did that happen and how was that decision made, and then how did that continue? Because once you make those kinds of choices, then you're going down a path that you might not be comfortable with. I think that's one of the things that we as prescribers have to realize is what our comfort levels are. And you know, if we're not comfortable, then it's awesome that we have all of the other services, the other not only the consultations, but the community supports like you all have to help us out with that.
I found it really helpful when I've been able to sit down with people, and because I have more time than the providers usually do, to ask all of these questions. And when the patients feel listened to, and when they're actually able to answer these questions about where's your specific pain, when is it the worst, when is it the best, tell me about what time you're taking your medication, you know, when is the medication wearing off, and they actually start to paint their own picture of their pain. They actually glean some of their own insight and learn something about themselves, and they actually become really more involved and more willing to listen, and it becomes way more obvious who is really in it and willing and wants to participate in their own care and is willing to try different things and willing to just really, really willing to be involved in their own care versus who is maybe not there for the appropriate reasons.
Jen brought up a great point that I have seen too in the past, where our clients are coming for medications for someone else, and we don't recognize that or know that until we do a drug screen and they don't have any opiates in their system or something like that. And that's an unusual, very rare happenstance, but we have to be aware of all the possibilities and the situation that this person has in their home.
I also have the luxury of spending an hour or more with patients. My practice isn't driven by RVUs because pharmacists don't get paid as providers. So like Andrea, I can spend that time. And so in my pain management clinic, I have just a medication management part of it that I run. And I get a lot of referrals from primary care providers from the community who don't have that kind of time. And so when I have folks come in, immediately what I'm going to do is say, hey, I grew up by Decorah, and I'm going to make that personal connection and then say, oh, Dr. Gastala, you know, sent you over here. She wants to, you know, get a little bit more information. She doesn't have all that time to spend with you. And I think it sounds like there's a lot going on with you. You know, let's sit down and talk about that. Let's talk about your medications. Let's talk about, you know, what have you been doing in Des Moines since you moved? You know, that whole kind of personal thing. And so for me, when I see my patients, particularly returns, a lot of the time it ends up being more of a social visit, and we still get the science done, but a lot of it is social and making that connection. And sometimes you all don't have that kind of time.
And I think what really happens is they're getting kind of that, like you said, that socialization and that contact, and their mood lifts. And what we found after, you know, starting our program in 2014, from 2014 to 2016, the amount of people whose medication list became, you know, more, their meds, became more compliant. The inappropriate use of medication went down. It really changed, but it's because they had more time with people.
How do you feel pain contracts? Are they useful?
We use them. It's part of the agreement, and it's not punitive. It is what it is. That is part of the agreement.
Yeah, I don't think that's new anymore. Patients, they've all heard of this.
Yes, we use ours.
And even in our palliative care group, we use them. In our hematology oncology group, we use them.
We use ours. Ours is blanket. Ours can be used for any controlled substance. Ours is just a controlled substance agreement, so we can roll it out for Adderall, Xanax, whatever we want.
Can you expand on what is really included in those pain contracts? I know there's some clinics that are struggling to do that.
Basically an informed consent and a controlled substance agreement. So it basically kind of goes over the signs and symptoms of withdrawal, what addiction is, what dependence is, It talks about what can, if you're operating a motor vehicle, that you need to use caution. It says that you agree to only get your medications from one pharmacy. You know that you're agreeing to, you might have to do urine drug screens. Basically, you will be required to do urine drug screens routinely. Be nice to the staff. Keep us up to date with your phone number. Keep us up to date with your address. Only get prescriptions from one practice. You might be required to sign releases of information. You'll most likely be required to participate in some sort of mental health treatment. You might be required to go to physical therapy, occupational therapy. You might be required to at least get a referral to a pain management specialist. You might not have to follow what they say, but you probably will have to go. You might be required to participate in some sort of a weight management program. Ours kind of goes over everything. Don't drink alcohol, don't use other controlled substances, don't sell your medication, don't buy other medication. Kind of a standard do's and don'ts of what's safe to do when you're using a controlled substance and what's not safe to do when you're using a controlled substance, and what the clinic could possibly do should you violate one of those agreements.
Being an FQHC, we do not ever, really rarely ever discharge a patient unless there's some sort of like concern for safety of like staff. But that doesn't mean that we are always willing to prescribe opioids or controlled substances. So we always make that very clear. Like, we cannot control if they violate because they're selling or whatever. Just because you violate the agreement doesn't mean we will not continue to take care of you or take care of your pain. We just can't use controlled substances to do that. And so that kind of lets them know at the beginning what the expectations are. Also, it tells you when they're allowed to have refills. Like, they can't call in on Friday night at 6 p.m. and ask for a refill. They have to, which really helps with the burden on staff. So that's also lined up how many days, and also to use the emergency room is not meant for chronic pain. That's also in there. That's not considered an emergency. But of course, if you have, chest pain or those sorts of things, it's of course appropriate to go to the ER, but the ER is not appropriate. That's also in our agreement to kind of help, patients.
So the urine drug screens are then meant to be a deterrent from using illicit substances while they're using narcotics. And
they're used to verify that they're taking what they're supposed to be taking, and we use ours to sometimes. We will have people that might say, "Well, I'm taking my amitriptyline and it's just not working." Mm-hmm. Well, we can test to see if you're taking your amitriptyline and you're not taking your amitriptyline or your gabapentin. So let's talk about that. Let's talk about why you're not taking it. Do you have some side effects from it? Does it make you feel sick? Let's just talk about it. It's a talking point. It's not always, a hammer and a nail. It's just, let's talk about why you're not taking it. Or like she said, hey, we're seeing that your hydrocodone is not ever in your urine, but maybe they have a family member that's taking it. Let's talk about that. What's going on? You have horrible pain, and rightfully so. That's not fair. We want to know about what's going on.
Then, of course, there's the debate, might as well open the can of worms, about cannabis and continuing to prescribe opiates. Does anyone else have a thought?
So according to Iowa law, it's not legal. So even though it doesn't matter what happens federal, right? It happens what happens in Iowa. So as a prescriber, I cannot continue to prescribe. And then have that honest conversation with the patient. Well, what helps your pain more? Right. But you have to choose. And I leave their choice up to them. They can continue to, use cannabis from whatever means they get it from versus the opioids, but I cannot prescribe at the same time. And even though alcohol is legal, there's still significant interactions, and I have that conversation. You cannot drink alcohol while you're taking your opioids. Like, even though it's legal, it's still, for me, very concerning because of the risk of respiratory suppression. So I have that just, conversation with them. But we always want to leave it in their court because, I'm here to help them and advise and be their doctor, but ultimately it's their decision on what they would like to do. And it's really important to give them that autonomy and be their choice. But I also don't have to prescribe either if I feel it's unsafe. So.
And the other piece from a behavioral health perspective too is that there are lots of folks that are prescribed both opiates and benzodiazepines. And so that's another question. If this lady had been taking benzodiazepines as well, then that complicates the situation.
That's what we see a lot of times too, is once these people break these pain contracts and are maybe discharged, which I know none of us like to do. I mean, lots of them will maybe fall back in my area again. And unfortunately what we see is a lot of the, methamphetamine use, not so much heroin in my area right now, but that's the really unfortunate part. All these people start self-medicating in order to, take away the pain or whatever that is. And then it's really now we're even worse off than what we were when we started this whole trip. So trying to, once again, meet them where they're at. I tend to try to always, you made a great point. Whenever I find myself working harder than the patient, I need to scale back. And sometimes they do just need to fail and then figure it out. Maybe they've finally gotten to that point, maybe I want to go in for treatment or whatever that is. So I think you made a great point of truly meeting that person and feeling them out, engaging the family. Once again, I think is really going to be a huge component. Hopefully it's a positive, supportive family, but I think that that's important too. And that's probably one of the most difficult points to get to is when they start self-medicating in addition to potentially, abusing the opiates. So,
but that's one of the most important things about having chronic pain is that PRAIN program is that you screen for opioid use disorder. And then if you do have that conversation with the patient, you need to know what are your resources and what are you going to do to help that patient? Because maybe their opioid use disorder got started because of a prescriber, right? So the medical system did this to a lot of patients. And so we also need, as primary care physicians, to help them whenever we do find that. Just like if you don't screen for diabetes, you're not going to find it. Same sort of thing with opioid use disorder. And then deciding, are you going to be a buprenorphine prescriber? Are you going to do naltrexone? What community resource do you have for behavioral health and therapy? And how are you going to help connect that patient? So it's not just tapering them and leaving them. Right. It's how are you going to help them if they want your help is always that question. So if they're ready.
Yeah. I think that's what I love is the, when I think 5-10 years ago, when I first started public health, we never had these community type of relationships. It was, well, we can't confirm or deny if we have this patient, and there really wasn't those, relationships. It was really the last 5 to 6 years, probably a lot of relationship building across our community. And now as we're becoming more regionalized, trying to really standardize our processes and looking at no matter where, if they're in a rural setting or more in an urban setting, hopefully they're getting those same connections, or at least maybe a provider or somebody would know where to find those connections, even if they don't know. Because I can even think with the Berry Hill Center, I mean, wow, how much that relationship has changed in the last 6 years. It's absolutely, it's staggering to me because we have such a great relationship and we're growing so much and the collaboration is so cool. And we just sit in our office sometimes and think back 6 years, wow, we were not where we are. We still have these problems, but we now typically know where to turn to, where to plug them into basically the system. So I am just thrilled to be a part of everything that's going on in healthcare right now.
One part of that is actually being in a somewhat smaller rural community. Mm-hmm. We have one emergency room to go to. So when you're called and this woman had been to the emergency room a number of times, it would have been the same emergency room. And then that's how you guys would have been identified. You would have identified her and she would have gotten services more quickly and more effectively. So that's awesome.
Do you also do some of the coordination between an inpatient hospital stay and coordination back into their home, primary care setting? That's something that I think across the country and in our state too, I think we've gotten a little bit better about. And I do a lot with the orthopedic surgeons, and we do some great big huge spine surgeries. And to have these folks go back to their community, a lot of times the primary care doc may not know they had surgery. They may not, nobody clued in the local people. Right. And they just traipsed off to the university or Mayo Clinic or whatever and decided to have this surgery and didn't tell anybody. So that's one of the things that we're trying to do a better job of is, you know, talking with the patient. You know, we still need their permission. It's right? But saying, you know, I'd like to, you know, give your local folks, you know, some idea about what you've been, you know, what we've done to you here, and who they're seeing when
And
they
the
go back home.
reconciliation. I mean, my gosh, there's sometimes I see people's med lists that are completely different.
Both in and out, right?
Yeah,
so it really
huge.
helps a lot, and particularly with the pain management. So it's very common for me when folks are in the hospital, I'll say, if they've been getting, you know, pain medication from somebody locally, I'm like, you mind if I touch base with them and, you know, make sure that we're all on the same page and we don't end up hurting you in the end? Like, oh yeah, definitely, you know, definitely, I want my local doctor to know. It isn't very often that I get somebody who says no. Right. And if that's the case, then we have to have the discussion about, well, I don't know if I can, you know, what we can send you home with, because it may not be safe for us to do so. And then they sometimes will change their mind about that. So, so I have really enjoyed that part of it too, trying to build those bridges. And I think the patients, most patients really appreciate that.
And Lee, along those lines, we actually have a question from a participant who said, who is included in weighing in on your care transitions process, and how does your team measure the impact of the effectiveness of that? And that can be posed to all of you, but just right along the lines of where you're talking.
We had, at the university, we had a transitional care team that was funded through a grant. I think the team still exists, but the grant expired. So I'm not quite sure. They had some key local communities that they were working with. For me, I've got a pharmacy resident right now looking at our follow-up for the orthopedics patients that I see. So when we have really complex patients, I see them preoperatively. I do the medication reconciliation, the whole history, the, you know, medication history, the whole thing that we would do for a new patient. Well, this is kind of a new patient going in for some kind of a surgery. So we make a plan. And then 9 times out of 10, the surgeons follow the plan. But then on the backside, you know, no matter what, you know, I may or may not be involved with their discharge medications, but I try and call them within about a week and say, hey, how are things going? You know, where are you at on your discomfort? How's your back? How's your knee? So for outcomes, I don't know. I mean, some folks are looking at how fast are we getting people off of opioids, because we have to get them off quickly. Well, you know, not every patient is the same, and not every surgery is the same, and not every admission is the same. And my spine deformity patients who are now fused from neck to sacrum are totally different than our medicine admissions, you know, who just also happen to have chronic back pain, but they're admitted for acute pancreatitis. So there's a whole different ballgame there. So with the orthopedics folks that I have focused on, a lot of the spine deformity ones, that's when my resident is going back. And as far as outcomes, it's really tough to measure this type of outcome, other than our survey will be asking the patient, do you feel that this, you know, this transitional piece has been helpful for you? You know, asking those types of questions. Was it helpful to have the pharmacist involved before, during, you know, and after your hospitalization? So that's kind of what we're looking at, more quality outcomes, because it's very hard to get objective data from those types of programs. Believe me, I've tried to find them. So we're looking more at quality outcomes for that, to be determined whenever the resident gets the project done. And also provider satisfaction. Is this working for providers? Do local folks appreciate that? Does the surgery team appreciate that? Those are the types of outcomes that we're looking at, because otherwise it's really hard to tell. And it's really hard to, I mean, it's not like we're making money, it's phone calls, you know, so there's not a lot of revenue generation with that. But I know that some services and some hospitals have transitional care clinics and teams, right? Do you guys have that?
Yeah, with FQHCs, a lot of them have nurse care managers. So if that person is being managed by the nurse care manager, they're going to check to see, are we getting ER reports? Are we getting reports from specialty clinics? Home health care, do we know what's going on in the home? If, you know, I probably would be calling Jen and saying, hey, what do you see there? Is there something we can do on our end to help you? And she would probably say the same thing to me in that instance. Pharmacy, you know, we really work back and forth a lot with the pharmacy. Behavioral health, huge component there. So if they're care managed, they're oftentimes getting that. It's the ones that aren't, that may not always have that system in place, but I think more and more agencies are trying to then do that on a broader base, or pull more nurse care managers in. And just to tag off of, I heard so many great things. I was excited over here in my chair, but so many of you talked about building up the relationship with the patient. That's really a key component, and setting the expectations. If people know where they stand, they know where that level is, there's safety in that, there's security in that, and that's so important for them. The patient having a choice. These are what the expectations are, and you can do whatever it is that you want, and allowing permission for you. Not that they need that permission, but oftentimes I think patients get scared. And Andrea, just when she was going through some of her questions and talked about how the patient would respond back, that is person engagement, patient and family engagement in action. When you can see that light bulb go on in a patient's eyes and they get excited, or you can see that shift when you're using the motivational interviewing, not talking at the patient, but pulling from within the patient, so that they're kind of driving that ship, so to speak. And it takes a team. And it's so integral to have a community, because no one person can do this for anyone. And so I think that's extremely important. The other thing that I heard that we might not have touched on enough is really the behavior component. There's coping skills that may or may not be there surrounding the pain management, or the diabetes, or exercise, you know, certainly with the grief component. So we want to always make sure that we're looping that back in, because we all need good behavioral health, and we all need to be reminded of that too, that we have to take care of ourselves, body, mind, and spirit, in order to really be successful. So I was just writing things down as you all were talking, because those are great pieces.
The other piece of it too is the cognitive behavioral therapy is part of the CDC guidelines for chronic pain management. So it is something that I think that we tend to forget, particularly in one interaction with a client where you're focused on treatment in the moment, and asking them about their journey through, you know, like I mentioned initially about this woman had a father who obviously passed away from alcohol abuse. Well, that sets her up to be potentially more at risk to abuse substances herself, but what traumas did she encounter as a child of this gentleman as a potential? But also, you know, I think that with regard to ongoing psychotherapy, or talk therapy, Dr. Berryhill used to call it, which makes total sense to me, is really integral to a lot of the aspects of this woman's care, not just the pain management part, but perhaps the diabetes part. I mean, diabetes and depression and substance use and pain all go together. You know, the number one cause for disability in this country is back pain. Number two is depression. And I know I sure see a lot of clients with diabetes and mental health services for whatever reason. Maybe that's sedentary lifestyle, poor nutrition, cortisol levels affecting insulin resistance, etc., or or maybe the medications that we prescribe causing their diabetes. So it is important to look at this particular client, but all of our clients with all these confounding conditions and look at them as a person and then treat their conditions next.
And not only that, as our population ages more, I mean, we've got a huge number of baby boomers coming through, heading towards their golden years, or maybe not so golden years. But we have a large number of folks who are going to be going through probably some major life losses, retiring from a job they were very active in, and you know, a lot of that, and to understand what they're going through. I mean, thinking about this lady after my dad passed, my mom wasn't cooking healthy anymore because she wasn't cooking for two people. Yeah. She's snacking out of a bag. And then she was diagnosed with diabetes, you know, so they don't take care of themselves like they used to, because either maybe they're not invested, maybe they don't have the energy, maybe they don't have, you know, the drive to do that because it's just them. And that's a factor, right? That's a whole, and it may not even be the depression. It may just be, oh, I don't have to make a meal tonight, so I'm going to have Cheetos and watch TV. You know, why? Because I can. You know, that type of thing.
And sometimes.
Well, I know, but that's when family and providers, both my mom's primary care provider as well as her daughters, of course, stepped in and said, okay, this has got to stop. But she wouldn't admit that to us, but she would talk to her doctor. You know, and she would kind of admit that. And I was like, okay, that's fine. But your doctor's telling me. So that more of that, I think, is coming to us and helping our older population be mentally healthy as they go through that change, because it's hard.
You bring up a great point, because as people age, they don't do change real well. And I only know that as I'm aging, I don't know. Right. But you look at the changes just in this brief scenario. You know, she's lost her husband, she's moving, she has a new primary care provider that maybe has the continued pain, but it's increased. Her A1C is increased. So that's a lot of different things that someone's going to have to go to. So those coping skills and ways that she can maneuver through that will be essential, because not everyone has that. Not everyone had the luxury of maybe learning those as they were growing. And certainly as we age, we don't always have those abilities. So you know, maybe her cognitive skills are not where they once were at some point. So looking at all those factors, but I think, you know, that does happen quite a bit with folks that lose somebody. You kind of lose your motivation for why you were doing the things you were doing, and having to learn how to tap into a different motivation.
Just going to remind our participants that we still have about 20-25 minutes here. If you would like to ask any questions, please feel free to do so in the chat box. I did have another question come in. In building patient partnerships, how are you all defining community to ensure the most high value resources are available to the patient?
I think we probably through public health look at a lot of our community relationships through like our China HIP. So, you know, our community health needs assessment and health improvement plan. The nice thing is this most recent one, I know we worked really closely with UnityPoint, which is probably our biggest hospital provider in our area, and really kind of hone in and see what are or who are our best community resources. I know the social worker and the emergency departments really come up with a nice list locally anyways of, you know, your food pantries or your substance abuse help. I mean, our CFR locally, and we revisit these things often because unfortunately as we know, with a lot of these grants, they're here today, gone tomorrow, and that maybe that Upper Des Moines or that United Way no longer supports whatever it was that they were doing. So I would say it's just a continual process, and it takes a lot of communication and the nice thing is with all these kind of care coordinators through the FQHCs, through our patient-centered medical homes, through our public health departments, through our integrated health homes, and really across our region, you know, I'm not going to know in Calhoun County what your community resources are. Your local public health and clinics are going to know what you need. So I think it's just a continual process to know where you need to go. And this relationship is trust. You know, we talk about it's trust with the people that you work with on a local level. It's trust with your patients. It's their trust with you. So it takes a long time to get that. And honestly, this stuff takes a lot of time. And I don't think people understand how much time it really takes, but it's really cool to see it work when, you know, maybe you had more time than I did that day. And maybe the next week I had a little more time. And we always want to support our providers as well, because we know your schedules are really full. We just always ask our public health, please don't tell people no. At least just say, let me take the information and see what I can find out. And us being a little more urban, kind of, we try to feed it through us, because we actually, it was really cool. We have a community paramedicine program locally where the ambulance will actually go out the next day if they notice somebody came in with maybe chest pain and they hadn't eaten and all they wanted was a box of food. They can actually take the ambulance out non-emergent and just, you know, hey, do you have any food, or is there some food we can go get for you? And then they'll maybe refer them to us, and we can go in and again kind of reevaluate. So it's just really this network. It definitely in our Fort Dodge, Webster County area, but we're really looking at that the local levels too. So
if you look at the social determinants of health and try to have a few answers in your local community for each of those, that's a really great way of coming up with a list of resources, of community resources. And then you can also use that to identify gaps in your community, which then you can work with the Department of Public Health or other local resources. Maybe it's need help with electricity or lack of a food pantry. But you know, the social determinants of health determines most of the patient's health, right? I think it's like 60 to 80%, right? The rest is us, but not much. So, but it goes through each of those things that can affect it. And if you can have a couple answers or a couple resources for each, then it should pretty much cover most people. And that's one of the things that we have tried to do, because we can't do everything in our clinic. Even at FQHC, there's lack of resources too. We are lucky in certain regards, but there's still significant amount of resources that we don't have, and so then it helps fill in those gaps and then update it every 6 months, because you're right, grants come and go and things change. So right, true.
So we did have another question come in. We work with several clients who have been on methadone for years and years. At what point do providers titrate down the dose and try to get them off methadone?
Great question. So
I think it depends on what they're using the methadone for. I know that at our clinic, if they're using it for substance use disorder, that needs to really be done that's supposed to be done at a special treatment center versus a family medicine clinic. But I know that some places and some patients were started on methadone, and then by virtue of just whatever circumstance, their family medicine prescriber happened to just continue the methadone for them. So I think it's important to figure out why exactly they're on the methadone in the first place. I guess I can just say, and I know I'm not a prescriber, but just through working with buprenorphine patients and through working with the pain management patients that I have worked with, one technique that I use is to start asking them. We spend a lot of time asking patients when you're taking the medication, why you're taking the medication, and what you're feeling when you take it. Are you taking it in the morning because of physical symptoms? Are you taking it in the morning because of habit? Do you take it at night because of physical symptoms or habit? Are you taking it because you're actually having pain? We spend a lot of time, and maybe sometimes they miss the dose. We spend a lot of time listening to that and listening to the patient. And if at all possible, we try to let the patient guide that decrease, because it's their idea. They're motivated to do it themselves. They're invested. We provide them with a little bit of knowledge about maybe the CDC guidelines, about the morphine equivalents, about the chance for overdose or respiratory failure. And then you know what our goal may be, because we maybe don't feel safe. Maybe we don't think methadone is the best medication. But that's what we have tried to do.
And it's really, what you're saying could be extrapolated to tobacco cessation, you know, in some ways. You know, why do you feel like you need that next smoke? When you know, so it's not really difficult. All it is, like we're saying, is listening to the client and having them be in charge of their care. And
it just really seems to work much better when they're saying, you know, I really don't need to take the dose first thing in the morning if it's a 3 times a day dose. Okay, well, then why don't you try taking a half a pill in the morning? And I'm lucky that I have really good supportive providers that we work together really well, and they'll, you know, I'm just really lucky. So we have a really good team. As long as it's safe, I would never say, you know, stop or whatever, but they really listen to the patients. And if we can self-guide it, the other thing to consider is that some insurances won't pay for methadone anymore. So that's another motivating factor.
I would echo that. I was asked the same exact question yesterday by our solid organ transplant team because they have folks that come in on opioids for various and sundry reasons, looking for an evaluation for organ transplant. And they said, well, what do we do about the patients who come in on methadone? And my first question was, well, why are they on it? You know, because if they're on it because of a heroin addiction, that's a whole different ballgame. And if you talk to the folks in the chemical dependency world, many of them, not everyone, but many of them say, okay, opioid use disorder is a chronic disease. Would you taper someone's insulin? Would you take someone off their statin? Probably not, right? Because these, in the end, can be life-limiting diseases. Okay, heroin addiction, if it goes unmanaged, can be life-limiting addiction or a life-limiting condition. So many people in the chemical dependency world will say that once they get on a stable dose of methadone, we should not mess with that because it's been shown to reduce mortality in the long run in that population. And buprenorphine, the data is still kind of building with regard to which is better, you know, with regard to that. But yeah, if they're on methadone for opioid use disorder, then they're going to be managed by those specialty clinics. And if folks in primary care are ending up with patients that come from that area, and I've seen them, you know, they just kind of ended up
somehow
they either the clinic closed or whatever, but somebody unknowingly, you know, kept it going, whether they were aware of the law or not. They kept it going, and then it's like, okay, now what do you do? But if they're on it for pain, which is very common, because at one point methadone was about the only thing the insurance would cover because it was cheap, and we use a lot of it, not only in our pain service but our palliative care service uses it quite a bit because it's relatively inexpensive. It's oral liquid, it's tablets, it's, you know, IV if you need it, so it's relatively versatile and inexpensive. And but if they're on it for chronic pain, almost universally, I will test optimal dose. And I'll talk with them about the long-term adverse effects. I mean, look, suppressing the immune system and causing hypogonadism and osteoporosis and hyperalgesia, and not to mention any of the addiction issues. The stuff that I'm worried about is the stuff that can hurt them, you know? And so it's like, oh, if you're still having 10 out of 10 pain and you're taking 60 milligrams of methadone, I have to wonder if it's really doing a lot for you. Because a lot of times people don't build a lot of tolerance to methadone because of its pharmacology. So I'm talking with them, just like you said, Andrea. It's like, so what if we just tried like a half a tablet instead of a full tablet in the morning and just kind of see how you do with that? I mean, just to test, to get them, maybe they do need the methadone. But let's find the lowest dose that's still effective, and maybe we can reduce some of the risks for adverse effects. And I've got folks who come in who do have osteoporosis from their chronic opioid therapy, and they do have hypogonadism, and that gets better when we reduce the dose.
And I think it's cool to celebrate those successes with the patient. Right? I mean, I'm a cheerleader half the time. I'm more of a ball player, but, but oh my gosh, I'm so proud. You did such a great job. I mean, just really giving them, kind of empowering them back to say, I knew you could do it, and just being that support system there for them, because not everybody does have a good support system. So I really think just celebrating those successes is huge for people and for their self-confidence as well.
Absolutely.
I think as a primary care provider, though, who doesn't work in a specialty pain clinic, it's very scary to prescribe methadone. And I think you need to recognize that and embrace that, and also realize where you feel like you're most comfortable in terms of safety. So if you do not feel comfortable, then refer them to a pain clinic, because the CDC guidelines do make recommendations on the amount of milliequivalents that primary care providers should be prescribing, which is max 90, and that's for non-palliative patients, right? Non-cancer, non-palliative. So if you don't feel comfortable, then don't. Doesn't mean you have to prescribe it, get them to where they need to, or switch them to a medicine that you're more comfortable with, and that you can, your pharmacist or you can get help with, but don't necessarily prescribe something just because they've been on it for 10 years for chronic pain. It doesn't mean that it's the best medicine. Maybe it was the cheapest and most available, but now, you know, they're older, you have to worry about long QT syndrome. There's lots of other side effects and things that you have to worry about that you want to consider. So just because they've been on it doesn't mean that you have to, you know, continue to try. You can try to switch to something else. In terms of, and then being at an FQHC and being primary care, if you do have someone with substance abuse disorder, you can't. You're not designated a methadone clinic. That is a special license, and so then there are protocols where you can switch them to buprenorphine if you're a prescriber. If you have your DAX, and so that's something that can be done. And buprenorphine can be, safer in some instances. And then in terms of how long they should be on it, if it is for addiction, I feel like there aren't great studies out there on how long and what the most efficacious in terms of timing, but you want to do at least a year, because that's how long it takes to stabilize your life and for your dopamine receptors and you become balanced again. But after that, it's really dependent on the patient, right? I have some diabetics who worked really hard on exercise and healthy eating, and I've been able to get them off of their medication. Same with statins too. And I feel like that, if we're going to use chronic disease as a reference, you do have that subset. I have some patients who got on it after a surgery, and they became addicted, and their goal is to be off, and that's okay. So looking at it as a spectrum rather than just boxing everyone, okay, you have a substance use disorder, you have to be on this for life, is not necessarily always the best thing either. Making everyone taper off at a year is also not an answer either. So it really has to be patient dependent what their goals are. If they've reached those stabilization and they're interested in tapering, again, it's a spectrum. So I think that that's really important conversation to have, because some of my patients who've transferred have never been asked if they've ever wanted to taper. And that's it. And they said, I thought I had to be on it for years. It's like, well, no, not necessarily. It's up to you and your situation. Maybe you don't need to be on it for forever. Maybe things have stabilized.
Or like they were talking about, maybe you don't need to be at that high a dose forever.
Sure.
Yeah.
It goes back to what you were saying about patient, the relationship with that client, with that person that's in the room with you. If you aren't comfortable prescribing something, whether it be an antipsychotic for schizophrenia or methadone for pain management, then you have to, I think it's best to be honest with the client. Like I was saying in the beginning, I've seen so many people that have said, I can't get my pain medicine anywhere, nobody will give it to me. And then I ask them why, and they tell me various stories about how they were refused those medications, and that includes other scheduled medications as well. And really, in the end of our conversations, they are still sort of denied that medication in some instances, but you don't feel that way when you're leaving the office if you feel like you're heard, and then both of you are more comfortable in that relationship. So I think that part of it is obviously very important.
So we did have another question come in, and I think this really pertains to healthcare in general. It's a question that I think everybody has been asking. So the participant said, information is power. Where are your organizations with data integration?
Halfway there, I would say. You know, I think that if our clients are being seen in our purview of our electronic health record, it's very advantageous. I think that, like Jen was talking earlier, if one of our clients, you know, there's some situations like with the transition of care that you were talking about earlier, stays in the hospital are so short that sometimes we were like, oh gosh, that our client was in the hospital, now they're out, and we didn't, you know, medicines might have been changed, the coordination of care wasn't there, even when we see that they were there over a weekend or whatever, if they're in our electronic health record. So if they're part of our organization, then it's one thing, but if they step outside that organization, it's another. We're really working hard to integrate that care from transition, but also within our services. We have co-located primary care through a PBHCI grant at Berry Hill. We're halfway through that now, and it is amazing to see how that coordination of care is very helpful. I'm doing some of the primary care now, and just yesterday, for example, I had a client in that was asking about a particular medication, that was asking me about it for pain. He had just seen his psychiatric prescriber, and I just said, wait a minute, I think I just heard him in the hall, let me walk outside. And so I grabbed him, he came in, we both sat and talked to that client for maybe only a minute, and I know that he had a better outcome from that visit because both of us were there. Then I grabbed the person from the integrated health home area of our office and asked her to follow through with this particular individual, and that worked out great. I think that within the hospital, we're also sending our IHH staff, integrated health home nurses, are going to the hospital to see those clients sometimes when they're there, so that we can both inform the providers there in the hospitalist situation so that they know what's going on with the client in the outpatient arena, but then they're also bringing information back to us. So some of it is actually still done in person, which of course I prefer. But I think that they're, like I said, I guess the way I see it is that we're halfway there.
And right now, I know we actually have access to Epic through a care link, through security agreements, which has been huge for us at Public Health. It makes things so much more timely, so many things. You don't have to wait for a 50-page fax or whatever. Literally, when a referral comes in, as long as they're a UnityPoint entity, I'll get right on the Epic Care link, which is a view only, and pull some of that information around allergies, med list diagnoses, last visit, those types of things. So that's been huge. The other thing with data, I think that's so hard for us sometimes. It's like our data, it's UnityPoint's data, and sometimes it's hard to get that data integrated. So that's been that's things that are even out of our hand. I mean, that's more corporate level stuff and our Department of Public Health stuff. So I would agree with you, we're getting there, but it's really difficult to get some of that data, to get those, to show those positive health and health outcomes. We can see it through our case studies that we do. We can see cost savings, but kind of across the continuum, it's just been really difficult to get that data.
I think it's certainly better and improving all the time. Mm-hmm. And we have that too. I mean, it's priceless to have somebody come in and be doing a medication reconciliation, and I can click and go, oh, look, there, you know, your doctor at UnityPoint, or, you know, whatever. And I have that whole list of medications from the outside pharmacy, the outside provider. I'm like, oh, can we just go through this too and just, you know, simplify and consolidate everything? Oh, sure, that should be the same. Oh, no. Sometimes it just isn't. But that's priceless. I mean, you don't want to screw up somebody's thyroid medication or, right, you know, something when they come in the hospital. That would be horrible. So that's been really, really nice.
Wonderful, thank you. Let's do one more question before we kind of wrap up here. We got about 5 minutes left. So I know that there's been some discussion around comfort and functionality rather than pain. Have you started to reframe how you talk about pain as well?
Sure. I think that we all have, and particularly, you know, I think in the mental health setting, I have clients that have schizophrenia or another psychotic illness that define pain, and you really realize that is agony. It's not physical pain. So I have people that come to me on Oxycontin and et cetera from their primary care or someone else. And really what they're describing is what I was saying. It's just agony. And so we've been able to change their regime and look at other alternatives. Medication is one thing, but also complementary medicine or adjunctive therapies. I think about it now as I kind of, with the old think outside the box. For me, I have to think outside the pill box. So if I can think outside that pill box and think about what other techniques that we can use, whether that's, I'd love for acupuncture to be covered by our insurances, but the other things that are, and it's more acceptable and accessible as far as other therapies, exercise, obviously, diet, but even chiropractic care and massage therapy and things like that. We're using, I'm sure you use all of that at the University of Iowa in the pain.
No, ma'am. We would love to have those things, and no one will pay for them. Do we recommend them? Yep. And then the patient says, well, my insurance isn't going to cover that. And massage is about $1 a minute. Yeah. So they can't afford to have that. Like, right. We would like them to.
Yeah, they have it at the Google headquarters. I mean, so
yeah.
if the employees at Google should have it.
Corporation in the state hospital. Corporate America is a pretty nice place to be. Yeah. Right. Well, with regard to the functional part of it, and of course the Joint Commission is all over this, and they make me a little bit nuts, in all honesty. But I've been doing pain management for 16 years, day in and day out. I hardly ever use the word pain. Mm-hmm. It's a 4-letter word to me. How's your back? What's your discomfort? Oh, your knees are bothering you. That's why you're going to have some surgery. What are you using for the knee? What are you using for the knees? What are you using for the back? Especially after surgery, there's data that says if you don't use the word pain, right, they actually do better. They use less pain medication. So we ask about comfort. And in my clinic, when I see folks back on a chronic basis, I use what's called a brief pain inventory. And that assesses their sleep and their walking and their working and their appetite and those types of things. And over time then, that's what I gauge how well that they're doing. Their pain scores hardly ever change. It's almost always 7-8, 7-8, 7-8, 7-8. But then when you start to look at what they've been doing, and again, it's more of a social interaction. So if they're going to see the grandkids and they're doing this and they're doing that and they're going on vacation, they went to Florida, like, that's awesome. That's awesome.
Right. We also use the brief pain inventory as part of our
it's nice.
And that's what I noticed when I was doing all of this stuff over the past couple of years, was that the numbers never changed.
No.
But what they were actually able to do was pretty amazing. The pain is like an 8 all of the time, but you have been able to go into that function and you have been able, so that's pretty great. That means that you have increasing functionality versus, the number's not gone down to 3, but you're able to do more than you were. So that's an improvement.
How often do you see opioid-induced hyperalgia? You mentioned it earlier. Do you see that very often? Do you all have aha moments? This is really what's going on. I think we miss that sometimes, but.
So I would have to tell you, I'm going to try and keep this really short because this is my area of love. I go around the country and I talk about glial cell activation. But I tend to see it quite a bit, but I don't see the norm. I don't see the usual patient. I see the unusual patient. And so when I see folks, I end up, and I don't necessarily use the word hyperalgesia, even though what happens is basically glial cell activation, which glial cells make up 70% of our central nervous system, and they're the bridge between the immune system and the nervous system. So even anytime I have someone come in with chronic diffuse pain, well, maybe it's not the opioid. Maybe it's their chronic pain that's causing this, or maybe it started off as an endometriosis, but now it's kind of the whole belly pain, and they had the hysterectomy, but they still have the chronic belly pain, and they're taking their opioids for it, and the pain isn't getting better, and so then they're taking more opioids for it, and the pain isn't getting better. And so then I have to say to them, you know what, this kind of diffuse belly pain now is we don't see any pathology there that's causing that. So it could be that your central nervous system is just sensitized. And we know now that these little cells in the nervous system actually have opioid receptors on them. And opioids stimulate these little guys and they kick out pain stuff. And so the opioid actually might be making the pain worse. And so it's, again, I have an hour with folks, so I can spend the time and talk about cute little glial cells and things like that. But that actually gives them a whole different perspective, you know, on, well, maybe it's not your opioid causing more pain, but I see a lot now, and I don't know if you all are seeing them, but cancer survivors. They're on truckloads of opioid because they needed it at the time, but nobody ever told them, gosh, you know, it's like, oh, cancer's cured, see ya, come back in a year, we'll do our scans. And meanwhile, they're like, what am I gonna do with all the stuff that I got? And so they come in, and just an example, I had a guy who had bladder cancer and painful treatment for that. And he was on several hundred milligrams of morphine. And he's like, you know, I have this chronic belly pain, and it's not just that kind of pain anymore. It's like, I'm just really uncomfortable. Mm-hmm. And so we started talking about it, and we're, you know, there really isn't any pathology there anymore. Could it be a neuritis? Maybe. Is it interstitial cystitis? No, they didn't think so. So we went through the whole, well, I didn't, but they all went through the whole workup. And I thought, well, maybe it's the opioid. And so I said, what do you think about trying just, again, a little baby dose reduction and see how you do with it? So he did that, and, you know, he came back, he's like, well, how's it going? And he's like, that's fine, no difference. Okay, well, what do you think about another dose reduction? Yeah, sure. And so we actually got him down almost 50% on his morphine dose. His pain wasn't worse, his pain was better. And he said, you know, I didn't believe you when you told me that this is what might be happening. And he said, and now I believe you. I said, well, it's hard because you've had this and you don't want the pain to come back because that was horrible, you know, but now it could be that the medicine that we were trying to give you to help you is actually in the long term making things worse. And so it's kind of feeling it out, and we never know for sure, you know, if that's what's causing it or not. But I always tell them, well, let's try this and just see. And then we use other like medications to get after central sensitization, like the gabapentinoids and some of the antidepressant type medications to actually calm down the central nervous system. Mm-hmm. But yeah, I mean, it's hard to, do I see it? Yeah, I probably see it quite a bit. But I never actually blame it. Something is happening, something is causing these symptoms. And yes, an opioid could be one of the things that could cause that.
Wonderful. Well, thank you all so much for your time. I really appreciate it. I know this is a topic that we're all very passionate about in this room, and we could probably talk for another hour and a half on the things that we really are passionate about, pain and really how we're treating with opioids. Again, thank our panelists so much for being here today. Your expertise was really greatly appreciated. I want to thank those of you who are participating on our webinar or Zoom platform. We really appreciate having you here as well. Just want to let those who are participating, you will be receiving a short SurveyMonkey evaluation, including that will ask for your thoughts on the next topic for our forum. So please complete that and return that to us. And then this forum was recorded and will be posted on the IHC YouTube later today or tomorrow. If you do have any questions, feel free to reach out to any of the IHC staff, and we'll be happy to get those to the panelists if we weren't able to get to them today. Thank you all and have a wonderful day.
Off to us down there.
This was good.
Oh, I
Especially with the level of data.